This is Dr. James Marion, once again with our Facebook Live from the IBD Center at Mount Sinai Medical Center in New York City. Today we have a very special guest, our President Levison Inflammatory Bowel Disease Fellow here at Mount Sinai, Dr. Adam Faye. Dr. Adam Faye is going to be discussing IBD and fragility, and frailness would be an older term, I suppose, and some of the research he's done in this area. Adam Faye graduated from Harvard with a degree in biochemistry, which we were able to do. I did not graduate from Harvard, but I have biochemistry at Berkeley, the competing, albeit public institution out on the West Coast. And then went to Weill Cornell Medical School, and then after that was a resident at New York Presbyterian Columbia, another overlap. I was a Columbia Presbyterian resident. And then we were able to snag him to be our IBD fellow. And the IBD fellowship here is a very competitive, sought after spot. And we were very lucky to get somebody of Adam's talents and skills. So Adam, welcome to our IBD Third Thursday broadcast.
Thank you so much for having me. It's I who feel very lucky to be able to train under you and Dr. Sands and Dr. Colmbell and everyone at the IBD Center at Mount Sinai. So thank you for having me.
Well, it's a pleasure, and it's a year is far too short. I feel like I'm just really starting to get to know you. But so Adam, we were talking about a couple of topics that we might cover, and blood clots, venous thrombosis, and which you've been doing some work in. And you brought up the idea, which is a relatively new one, about frailty and IBD. And that is a very intriguing concept and a very important one that's actually putting some sort of quantifying concepts around something that we've all known for years. So that's why I'm intrigued by it. So give me a sense of, one, what you mean by frailty, and what you mean, how is it different from aging with respect to IBD?
Yeah, I completely agree with you. I think it's an important topic. It's something that I think we're only starting to realize and really touch the surface of it now, really scratch the surface of this. And really, I think you're right. As clinicians and as providers seeing patients, we often think about frailty, but it's a little bit harder to quantify. And even within some of the research that's been going on over the last decade outside of inflammatory bowel disease with frailty, it's been a bit challenging to quantify. But it's really, and for me, what really gets me excited about it is it's getting away from this idea of chronological age. I think for too long, we take a look and our patients, some of them who are older, are actually fairly robust, and some of our younger patients are potentially more frail. So it's getting, are really putting aside this idea that age alone is a predictor of outcomes, and that could be hospitalization, surgery, overall mortality, things like that. Putting that aside and actually saying there must be something better, something that we can actually quantify, right? We all know 75-year-olds who are out running around visiting, maybe not now traveling the world with COVID, but who are out doing things, walking 10 miles a day, and are less likely to be frail. And we all know, patients who are 30, 35 who potentially are frail. So it's really about that. And so there's many different measures. I won't get into too much into them, but it's really about getting away from this idea of age and more towards quantifiable measures that can help predict who's at risk of outcomes.
Yeah, the one concept that I've been telling my patients, again, without some of the good work that is starting to coalesce around this thing, is, as you get older, and with IBD, our patients are quite young, right? They could be in their 20s, 30s, and 40s. So you age with them. And now that I'm getting up there, I'm always saying that, listen, this is like the hardest marathon race you're ever going to get into if you become ill in your 50s or 60s or 70s. And in fact, illness tends to happen more commonly then. You better be in good shape for it, because if you're not in good shape for it, it's a race that one can lose in a very big way. Now, so age-related diseases are, again, that's a term that, probably is so broad, and I'm sure there's some controversy about it. But, we have geriatrics. What are some of the age-related diseases that you specifically find linked to IBD that I think our audience might want to be more aware of?
Yeah, absolutely. So I think that that's a great point. I mean, as you get older, you are at higher risk for frailty. And what frailty is loss of muscle mass. There's different ways to measure it in terms of grip strength and walking, but it's this idea that you have a loss of physiologic reserve, just as you're talking about. When you're at the marathon, you really need that reserve. And if you start to lose that reserve over time, it's when you can start to get into trouble later on. And so what does years of having inflammatory bowel disease or repeated courses of steroids or other things, how does that actually play in to the development of frailty over time, where, like you said, again, at the end of the marathon, where we then start to realize all those effects from many years of downstream? That's what we're starting to kind of unravel and really look into now. But in terms of aging related disorders, we are seeing, again, these are mostly associational. So a little bit less so about direct pathophysiologic connections, but when we look at large, nationwide cohorts of patients with inflammatory bowel disease, we do see some studies that show a higher risk of coronary disease. Some studies haven't quite borne that out, but there at least have been some meta-analyses, which are studies looking at kind of combining many of the observational studies, and there does seem to be a link. So potentially our inflammatory bowel disease patients are at higher risk for coronary disease. Type 2 diabetes was a recent study that came out actually from Denmark, even putting steroid use aside. We know steroid use is often associated with diabetes, but even looking in the patients who really weren't on many steroid courses, or looking at patients who were on steroids compared to other patients on steroids in the general population diabetes. Dementia was actually a very recent paper that came out, both Alzheimer's dementia, kind of all-cause dementia. So again, using that term, but aging related disorders and how they're connected to inflammatory bowel disease, we really need to unravel that, because we are seeing a higher risk of these.
Yeah, and I really want to make clear to the audience, what we're talking about here are studies that are associative studies. So we're looking at something that may have some association, which is actually a fairly low bar to get over. So simply because you are a 22-year-old with Crohn's disease or ulcerative colitis now does not mean you're going to be demented. Just want to be clear on that. So
100%.
association is not causation. So just want to make that clear to the audience. So I guess, I think about some of my patients who have IBD, who are, fatigue is a part of it. It's a protein losing sort of condition. They can be anemic, and that the decades of deconditioning from that can lead to issues for some of them. And I'm, really trying to, optimize their treatment, trying to optimize some of these indices while I'm treating them, and encouraging them to take advantage of, when we restore them, right? But still, that headwind can really weigh. Why is this fragility? I mean, I can see it even just saying it out loud. Some of these are the consequence of many, many decades of disease, right? And these are diseases of a lifetime. These are not diseases that just go away. We can't come up with a vaccine within a year that just makes it disappear, unfortunately. But why do you think this might be specifically important to IBD?
Yeah, it's a great question. I think particularly because couple of things, but one potentially is with medication use like steroids and other things, we have to understand what the impact over time of that. Also, just like you said, inflammatory bowel disease is not a disease where you take a vaccine or you have something and all of a sudden it's gone. This is a disease that is obviously persistent over many, many years. And so what it actually does to the aging process, and I mean that on a physiologic, but also down to a cellular level. There are some reports and data that's actually showing some of the normal aging pathways that get upregulated. they may be upregulated with an inflammatory bowel disease as well. And it's really early to know whether this is, any connection there. But this idea that potentially if you have ongoing disease activity for 30 or 40 years, potentially this aging process, even down to a cellular level, may even be getting accelerated a bit. And so
Wow, that's
trying
interesting.
trying to understand and unravel that, and whether treatments actually modulate that, I think is a very interesting and very relevant question for our patients, because we obviously want the most optimal care. We want to prevent adverse outcomes, and at least from the retrospective data. So looking back at patients and classifying them at frailty or not, which is really not the proper way. The best way is really looking forward. So doing those measurements of strength and walking, but just looking at some of the diagnosis codes and making a surrogate marker of frailty, we see at least within the interim that it's associated with infectious risk if you start a biologic or immunomodulator, with hospitalization risk, with overall mortality risk. And again, these are associational studies, not really done in, in a prospective looking forward manner of evaluation. So certainly needs further validation and exploration, but it gets to the point where, again, maybe we shouldn't be looking at age. Maybe we should be assessing frailty, and maybe we should be assessing who's at risk to become frail and maybe actually intervening.
Wow, that is terrific to think about, because, I think often we gastroenterologists confront this head on, primarily when our patients become so ill that they require hospitalization for surgery, for example. So, they get, inundation, they become cachectic, they're, sinking into the sheets literally because they're so weakened by the condition, and obviously frail. Their bones have been thinned from steroids. They're on TPN. You're doing everything you can to revive them. And in the old days, we used to get sort of laughed at by sending them over to physical therapy to see if we could build up muscle mass that way. But, things have moved in a very, the pendulum is swung differently. And also the idea that somehow actuarial tables that just look at the number don't really tell us quite enough about how important it is to, get these patients optimized, get them into a remission, and pay attention to the whole patient.
That's exactly right.
So what I'm curious about, so you see a patient in clinic, for example, what are some of the ways that you are assessing their frailty when they come in?
Absolutely. It's a great question. So there are some validated measures looking at, just as you mentioned, nutrition, weight loss, grip strength is one, ability to walk a couple of feet, how long it takes. And these are all standardized. So if a 20-year-old or a 30-year-old or a 40-year-old or 50-year-old, it's standardized basically to your age and what quartile you might be within there. And so you start to have that assessment. There are some other measures that aren't quite as objective as that. There are some where it's a subjective clinician assessment who's been trained, usually a geriatrician who's at least has an understanding of frailty and has done some research and within that. But you start to understand kind of the patient's substrate, what they are there with, and basically how the therapies that you have, not only the biologics and surgery and thinking about that, but as we do at the IBD Center, nutrition, or psychologist, physical therapy, as we start to think about kind of years of management down the road, maybe, we start to think about intervening right now with nutrition, physical therapy, trying to optimize, and that actually may change outcomes. And that kind of also gets to your surgical exploration too, which is, I think, a great point. We have a lot of data about optimization and frailty before surgery, and we know that intervening and helping can actually improve outcomes. So I think it's incredibly important to figure out not only who's at risk to become frail, but also what interventions we can start to do along the way so that it's not 30 years down the road and now we have all these consequences of frailty that have resulted. And now maybe it's even a bit too late to really intervene and change the course, but we're actually starting to evaluate it back here and do that. So that way we can actually change the ultimate path.
Yeah. Well, listen, Adam, This is great. I mean, clearly, we're very lucky to have your enthusiasm. And I think this problem needs your enthusiasm and obviously is going to benefit from your keen intellect. I will ask all of our audience members to keep a sharp eye out for Adam Faye. You're going to be hearing more things about him and what I hope will be a nice, long, and illustrious career that started really at Mount Sinai.
Yeah.
Adam, any final thoughts you'd like to close with? I think we covered this pretty well.
Yeah, I think so as well. No, just thanks again for having me. I'm obviously very passionate about the topic. I hope we'll have more to come every year with more data and more knowledge about how this all plays out for our patients and how we can provide the best care we can. And hope everyone is safe and well during this pandemic.
Yes, and then we'll have to have you back to talk about it some more. Probably Grand Rounds will be the next venue for you.
Would love to.
So listen, I want to thank all of you for joining us for this third Thursday Facebook Live broadcast from the IBD Center, where we've been talking with Dr. Adam Faye on IBD and Frailty. I encourage you to look at it again if you have the opportunity and share it with others who you think might benefit from hearing this. So Adam, thank you once again. And I look forward to seeing you all next month for our next third Thursday broadcast. Be safe, and when it's available, get vaccinated.
Absolutely.